Good evening. My name is Stuart Autry with Pinnacle Meetings and Events, and I'd like to welcome you to this presentation on AMD. I'm bringing this program across Canada and the States. I've got just a few housekeeping items to cover tonight. You will receive 1 hour of COPE approved credit. This has been approved as a live CE event. We will send CE certificates out to everyone following the program upon completion of the event survey that we send out. The survey will be sent electronically via email tomorrow to everyone before noon tomorrow. We will also upload these hours for you to ARBO using your OE tracker number and submit directly to the Texas boards for all those licensed in Texas. Just a couple of items for this evening in terms of correspondence with the moderator and with the speakers. Please be sure to use the chat box if you have questions regarding the program itself, the certification, your certificate, ARBO, anything along those lines. If you have direct questions for the speakers, please use the Q&A box, as that will be the method with which we will communicate those questions to the speakers. The speakers will answer questions at the conclusion of their program, so they will not be stopping during their presentation. So please hold questions till the end and realize that we cannot recognize you if you raise your hand. Please post questions in the Q&A. I'll start off by introducing our first lecturer this evening. Dr. Jeff Gerson comes to us from Kansas City. He's a graduate of the University of Indiana School of Optometry. He then went on to complete a residency in ocular disease and low vision. He lectures across the states and internationally and is a real key opinion leader in optometry. So please welcome Dr. Jeff Gerson. Thank you for joining us, Dr. Gerson.
Stuart, thank you. And again, thank you most importantly for everyone who logged in here. We've got over 1,200 people logged on, and that's really incredible. So thank you everyone for taking your time out to join us. So this is something I get really excited about talking about AMD and what we can do about early AMD, because early AMD is really what we need to be taking care of and lives in our offices, whereas people with advanced AMD, those are the people that end up in the retina specialist offices. So hopefully we can prevent some of that and have better outcomes for our patients. And that's exactly what Joe and I are going to be talking about tonight. So standard disclosure slide that I've worked for a number of industry companies, and hopefully what you'll all see is that it's an unbiased, science-based talk. So I want to start with a little poll, and I want you to answer yourself, for yourselves. Does your practice see more AMD or more glaucoma? And I understand I'm an American doctor talking to a primarily Canadian crowd, but I can promise you, and I'll show you the statistics to back it up, that the numbers in the US, as far as percentages, are the same as Canada. So let me ask you the next question. That would be, does your practice see more AMD or diabetic retinopathy? Now, I'll give you a clue. Both of these answers, the answer is AMD. You see more AMD in the average practice than glaucoma, and more AMD in the average practice than diabetic retinopathy. But let's make it a little tricky. And let me ask you, do you see in your practice more AMD or glaucoma plus diabetic retinopathy? And you may be surprised to know that you can look at the numbers here, and these are Canada specific, that in Canada you have more patients with AMD than glaucoma plus diabetic retinopathy combined. You have more than 3 times as many people with AMD than glaucoma. Think about that. Every patient you see, every exam, you're looking at their optic nerve, you're checking their IOP, you're doing multiple tests for glaucoma. But how hard are we really looking for AMD? There's more than 3 times as much. And then as we can see on the graph to the right, we know that as our patients get older, more and more end up having AMD. And surprisingly, for our patients over age 75, it's about a 1 in 3 chance. So it's something that, depending on age, we should be seeing a lot of in our practices. So I wanted to start with a case, and this is a pretty obvious case of AMD. This guy's name is Naum. He's an 80-year-old guy, a Russian immigrant. I've been seeing him for a number of years. And just for a moment, I want you to look away from his optic nerve because he has advanced glaucoma. And I'll actually later in the talk show you his visual field and OCT of his optic nerve. But for right now, I want you to look at his macula. And what do you want to know? What are you going to tell this guy? Well, would you want to know that he smokes? Would you tell him about nutritional supplementation, about having AMD? This is a pretty easy case, right? Because he's got some large drusen. He has fairly advanced dry macular degeneration. So he has intermediate dry AMD and needs an AREDS2 type supplement. That's an easy one. But what about this patient? This is someone that comes into your office, 68-year-old coming in because they have diabetes, coming in for their annual diabetic eye exam, just routine exam, and they say, well, everything's fine, I just don't like driving at night. And we're too used to saying, well, as we get older, that just happens. As it turns out, it doesn't. As it turns out, as we get older, we're more likely to have age-related eye diseases, but losing vision isn't one of them. Anybody that has a vision problem, it should be because of an eye problem. So when someone tells you they don't like driving at night, what are the eye problems we think of? Well, what if I told you this person failed a dark adaptation screening? Well, now I know what the eye problem is, that they have age-related macular degeneration, even though you can't see it clinically. And Joe and I will talk a little bit about that. Now, just because you don't think you see it clinically, there was an important study done about 2 years ago that what they showed was these were patients where the doctors were told, what we want you to do is do some eye exams on patients over age 60. And all you need to do is let us know, do they have AMD or not? Take a fundus photo, send us the fundus photo, and we'll grade you on how good of a job you did. So basically saying, we want you to answer one question and we're going to be looking over your shoulder, so you better do a good job. And as it turned out, 25% of the patients that were deemed to be normal actually had AMD. And so there's patients that we're looking at that everything looks just fine, but they actually have clinically evident AMD. Never mind all the people that have subclinical AMD, and I'll talk about what that means because it's a really important term. Why is this all so important? Well, it's so important because once our patients develop advanced AMD and they need injections, almost 80% of the time, if they need an injection, their vision is already worse than 20/50. About half of those, so about 40%, are already legally blind. Now, you know what the best predictor of outcome from injections is? The best predictor of outcomes is what's your vision when you start. So if you have lousy vision when you start, you're going to have lousy vision after injections. Why is this important? Well, where we come in is diagnosing the disease earlier. If you know someone has a disease, you watch them more closely. You find changes sooner. And that's why it's so important that if we use dark adaptation to identify patients earlier who have AMD, and we start following them more closely, the graph is likely to shift to something like this, where the vast majority have good outcomes. And it's a small minority with bad outcomes. Now, I know with AMD, we're always thinking about risk factors, and this is a really important point. What are risk factors and what are diagnostic? There's some that are very well established, others that are still recognized, maybe not quite as well established. But we're always looking at risk factors. Then maybe we look for symptoms, like, is your vision 20/20? But we all know someone can have bad AMD and sub 20/20 vision. So visual acuity is not a great test for macular degeneration. We talk about Amsler grid, and we've all had patients that have AMD with no Amsler grid changes, and it amazes us. So we look for symptoms, but oftentimes it's really hard to pick up the typical symptoms that we're used to asking our patients about. Now, once we do identify macular degeneration, the traditional classification scale is this one done by the Beckman Committee, where patients either have no AMD, early, intermediate, or advanced. Advanced being either neovascular AMD or geographic atrophy. And intermediate AMD is someone that has at least one large drusen or any pigment abnormalities. And so this is the classic scale. Notice it doesn't take into consideration dark adaptation. And again, we'll get to that in just a little bit. So how good are we at measuring drusen? Admittedly, probably not as good as I think I am, or as many of us think we are. Let me start with showing you the central retinal vein as it comes out of the optic nerve. It's 125 microns in size. Why is that important? Because large drusen are at least that size, the diameter of that vein right there. So here's some examples. There's a drusen that's about 63 microns in size, so about half that. And there's one that's somewhere in between 63 and 125. And in the middle there, we have large ones that are at least 125. And those are the ones that we really look at, because once someone has any large drusen, it's intermediate dry AMD, they need to be on an AREDS2 supplement. All right, so what's really happening in the retina, or in the macula specifically, as we form macular degeneration? So here you can see the schematic on the right side. Everything looks normal. the choroidal capillaries, Brooks membrane, RPE photoreceptor. And so this is how it looks when everything looks healthy. Fundus photo on the side, everything looks great. But what happens is we start to have this little cholesterol layer that builds up along Brooks membrane, these little deposits. What these deposits are doing is they're impeding the in and outflow of nutrients in and out of the retina to get to the photoreceptors. But surprisingly, this is what the fundus photo looks like, completely normal. The only way we'd really be able to see this is with an electron micrograph, which obviously we don't do that in live patients. Then it starts getting worse. And this is a pretty dramatic looking schematic, but guess what? Funduscopically looks the same. It's not until we actually see drusen like this that we start to see anything clinically as we look into our patient's eyes. So what I'm trying to demonstrate here is AMD is there. It's present far before we actually see the drusen that we see in a picture like this. So here again, we have the continuum of truly normal looking funduscopically, and then finally abnormal looking funduscopically. But in these two stages where it's abnormal but looks normal funduscopically, these are patients that have subclinical AMD. It's there, we just don't see it. The drusen are just the tip of the iceberg. So this is an example of drusen, but this is what's really happening. These are all those deposits, those basal linear and basal laminar deposits along Brooks membrane. And so what happens is all these deposits along Brooks membrane, as I mentioned, impede in and outflow of nutrients. So it gives us a localized vitamin A deficiency, which then leads to impaired dark adaptation. That's why it's such an important test. So what we need to realize is AMD, whether it's subclinical, early, intermediate, it doesn't matter. It's all age-related macular degeneration. It's all the same disease. And really our job is not to let our patients fall off the cliff, because once Humpty Dumpty falls off the wall, it's hard to put them back together and make things normal again. And so we need to find our patients earlier, not when they're intermediate, certainly not, just beginning to find them when they're wet, and we need to pull them back. So much earlier stages of AMD, we need to identify, pull them back. Well, how do we pull them back? Why do we want to do that? We'll get to that in just a minute. So I've mentioned dark adaptation a couple times, and what I want you to know is this is not just me speaking from clinical experience, although in the Q&A, if you'd like to know my clinical experience, I'm happy to share it with you. But this was a study done at University of Alabama, Birmingham, and they took 325 adults with normal-looking funduscopic appearance. A quarter of them failed dark adaptation testing. And what they found was 3 years later, those that failed dark adaptation testing were twice as likely to have clinically evident AMD. So we know that impaired dark adaptation precedes clinical AMD by at least 3 years. So really the way to classify AMD is we need to add in subclinical. So these are patients with no funduscopic findings, but have impaired dark adaptation. These are patients that have macular degeneration, you just don't see it yet. That's the important thing. So what we need to realize is impaired dark adaptation is not a risk factor. Risk factors are things like MPOD, genetic testing. Those assess the likelihood of developing a disease. Impaired dark adaptation indicates that AMD is there. It is a diagnostic test. Huge difference. You can have all the risk factors in the world and never get a disease, but if you have the disease, you've got it. And the risk factors may not be nearly as important anymore because you've got the disease. What's important to know is that clinical testing for dark adaptation is now a practical thing to be able to do. It's a functional test for measuring dark adaptation quickly and effectively in a clinical setting, gives you objective results. And what's super cool is now it can be done with a head-mounted device. Does not need to be in a dark room. Patients don't need to dark adapt. You can do it on any patient, anytime. Makes it really practical for those of us like me in private practice that have all sorts of constraints. This takes those constraints away. Now, does dark adaptation really work for identifying macular degeneration, or how well does it work? Well, this study done at these prestigious institutions showed us that using dark adaptation to identify AMD is over 90% sensitive and over 90% specific. So rhetorically, I'll pose a question to you. How does that compare to visual fields and glaucoma, which is standard of care, right? It's at least as good as visual fields for glaucoma. And we need to realize that. So what we need to do is we can do a screening test on our patients. And if it takes them longer than 6.5 minutes to dark adapt, we know they fail. If it's shorter, fine, that's great. Normal, see you next year. If they fail, we need to have them come back, confirm the test with an extended test. That's like doing a threshold visual field, and start with our treatment recommendations for macular degeneration like you see on the bottom here. That'll go into a little bit more detail in just a moment. And then obviously we need to manage these patients through medical office visits, where these are patients that need to be seen more than just once a year and require further care than just our traditional refractive care we may be providing. So let me ask you guys, who thinks that choroidal neovascular membranes need or deserve to be treated? I assume all of you. Who thinks that intermediate dry AMD needs or deserves to be treated? AREDS 2 showed us it did, so I'm going to assume all of you. Who thinks that mild or subclinical AMD needs or deserves to be treated? That's a little trickier, but I'll tell you, I do. It's a stage of macular degeneration. It needs to be treated. It needs to be taken care of, and not just let's wait and see. So what are some of the things we can do? Smoking's by far the largest modifiable risk factor, up to 5 times the risk for smokers versus non-smokers. What's crazy is that over 90% of patients with AMD were never advised to quit smoking, and over half of people with AMD don't even know that smoking's bad. Everyone should know that smoking's not good for anything, right? I mean, if you roll up kale and smoke it, it's probably not good for you. It's bad. Smoking anything is bad. And that sounds just so simple and intuitive to us, but to our patients, it's not so much. They don't all know that. So here's the lowest hanging fruit, is to make sure patients know, number one, smoking is bad for you when it comes to AMD, and you ought to consider smoking, or quitting smoking rather. What are some other things we can do for our patients at all stages of macular degeneration? One is nutritional supplementation. Now you might say, well, the AREDS 1 study didn't show any benefit to patients with early AMD. And maybe if you guys ask some questions about that, I'll be happy to go into more detail. But what AREDS 2 definitely didn't say was you shouldn't. And there are plenty of smaller studies that show benefit, especially in carotenoid-based supplements, that we can help our patients. If nothing else, we can improve their vision, whether it's visual acuity, contrast sensitivity, shape discrimination, other metrics we can measure. We can improve people's vision through nutritional supplementation. So that becomes very, very important. Number 2, other lifestyle modifications. So diet, exercise. So diet, we can make it simple. We can say, you know what, eat more green leafy vegetables, less refined carbohydrates. If a patient asks me, well, should I do a Mediterranean diet or should I do a paleo diet? My answer is yes. If you're even considering anything like that, you're ahead of the curve. Any of those are better than a standard American diet, and probably better than a standard Canadian diet too. Exercise, what's important to know about exercise is it doesn't take a whole lot. Just doing some exercise does a world of good at preventing progression to advanced macular degeneration. Systemic disease management, taking care of things like high blood pressure, cholesterol, cardiovascular disease, and diabetes, all contribute to better outcomes when it comes to macular degeneration. And then considering light protection like UV and blue light blocking lenses. Now, what's great about all this stuff is the message that I give to all my patients when they have subclinical AMD is I talk to them and say, you know what, I'm going to ask you to do 5 things. 4 of them are the exact same as any other doctor you ever seen. Only 1 is going to be a little different. The 4 that are the same are, I want you to make sure to not be obese, and I want you to either quit smoking or not start smoking. I want you to have a healthy diet with more green leafy vegetables, less refined carbohydrates, and I want you to get some exercise. You heard those things before? The answer from everybody is yes. The 5th one is I want you to take a specific supplement for your eyes. Here's what it is. And that's it. I make it a very, very simple message. And I know that by delivering that very simple message, I can do a world of good for my patients. So how can I graph why this is important? So let's take our patient Jane Doe, age 59, that maybe we diagnosed with subclinical macular degeneration. So she came in for a routine exam here, and then she failed a screening dark adaptation. I have her come back. I want to confirm that with an extended test. Again, kind of like a threshold visual field. And we see that her time to dark adapt was 8.2 minutes, longer than 6.5. So what I say to Jane is, Jane, you know, what you have is very, very early macular degeneration. The good news is it's not bothering you now, and hopefully with what we're going to do, you'll never be bothered by it. And I turn it into good news. And what's really odd is when I have that conversation with patients, almost every time it ends with patients saying thank you, which is kind of crazy, right? I just told someone they had macular degeneration and they're saying thank you. So I have Jane come back in 6 months and we check and her number is very stable. I check it again at her next annual visit. It's remaining stable. Check it again in 6 months. It's stable. Have her 6 months again later and look what happened. The time went up quite a bit, up to over 12 minutes. So that tells me that whether I can see it or not, her disease is progressing because of this number. It's like seeing a progression in a visual field, even if the optic nerve doesn't look any different. So what I'm probably going to start doing is monitoring a little more closely so that if she converts to wet AMD, I find it earlier with better vision so she can have a better outcome with her treatment. So finding early in order to monitor more closely ultimately should help people to have better outcomes. So what we're trying to do here is identify early, start our treatment. Now you might be saying, well, are you treating someone by giving them supplements and talking about exercise and doing those things? Absolutely, because that's the best treatment. And so what we're trying to do, and so now this term is really, everybody knows it, what we're trying to do is flatten the curve, right? So just like with coronavirus, we don't want to see a steep incline in cases. Well, in someone's AMD, we don't want to see a steep change in severity. We want to flatten that curve so that hopefully it doesn't progress, or if it does, it takes much longer. So the whole idea is find it early, flatten the curve, and improve outcomes. Delay progression with early intervention. So an analogy that I use all the time is to that of glaucoma, because glaucoma is something that is top of mind for us. Again, even though we only see a third of it compared to how much we see macular degeneration. But what we're all doing with our glaucoma patients is we test for structural changes or look for structural changes. We test for functional changes. We're doing OCT. And we're looking at risk factors like IOP, corneal thickness, family history, age, race, all these other things. What are we historically doing with AMD? Historically, all we're doing is looking at structure. And if there's no structural change, we don't do anything. What we need to realize is we also need to be assessing functional change, not by visual acuity, not by contrast sensitivity. By the time those things are affected, it's too late to be early. So checking for functional deficits, even in patients with subclinical macular degeneration, and then assessing risk factors and really looking at, are you at risk? If you don't have it, what are your risk factors? And if you do have it, what risk factors should we be addressing? Obviously, we can't address how old you are or your family history, but we can assess your genetics to maybe help us understand how often to see you. If you smoke, we know that's a risk factor. If you have poor macular pigment optical density, we know that by adjusting your diet, which is not very likely to happen, more likely to get you a carotenoid-based supplement, that we can help improve outcomes. Structure, function, assess them both, help patients get better outcomes. Now, I know some of you are still saying, well, gosh, I really want to do something about this subclinical macular degeneration. Is that a point at which we need to intervene? Again, let me flip it to glaucoma. If you have a patient that has pre-parametric glaucoma, are you going to treat it? Or are you going to say, you got a little bit of glaucoma, but let's just wait till it bothers you? Remember Noam from the beginning, the patient that I shared with you that had the obvious macular degeneration? This is his visual field and his optic nerve OCT. Now, mind you, this was his visual field the first time he came to see me. It's fixation threatened, right? It's just a few ganglion cells. It's not too many neurons away from losing central fixation. Do you want to wait until your glaucoma patients look like this to treat them? No, it's a silly question, right? The same thing is we don't want to wait for our AMD patients to have a really bad looking macula before we want to do something about it. Let me give you my clinical experience and what's happened in my office. So I did an IRB approved clinical study. And what I did is I took 100 consecutive patients over the age of 60, where I did a clinical exam and thought it was normal, did an OCT screening of the macula and it was normal, and did dark adaptation testing. And most of you will be shocked, unless you've heard me before, you'll be shocked at the percentage of patients that actually had subclinical macular degeneration. It was 39 out of 100. 39%. Now, let me go back to the glaucoma model. You worry about glaucoma in your patients over age 50 or 60. You check everyone's IOP. What percentage of patients that you ever check their IOP have glaucoma? What percentage of patients that have a high IOP, maybe over 20, have glaucoma? Probably less than 39. So your hit rate for doing dark adaptation testing is going to be exponentially higher than the hit rate you get from checking IOP. Now, I don't want you to misconstrue and think that I'm saying don't check IOP, but what I'm saying is we need to look at least as hard for macular degeneration as we do for glaucoma. And that's really the important message that I want to get across, just how much AMD is there and how hard we really need to look for it. So we're going to start to switch over presenters. And while we're doing that, I'm going to start to look at the questions while we're switching over. So the first question was, what equipment do you use for dark adaptation testing? So currently I'm using what's called the AdaptDx, which is a tabletop unit. The head-mounted one that I showed a picture of but didn't have any labeling on it is called an AdaptDx Pro. And those are really the only two available devices. They're manufactured by a company called MacuLogix. Would those pre-drusen changes show up with autofluorescence as well as dark adaptometry? The answer is no. So you usually will not see these changes with autofluorescence, just like you will in dark adaptation. So dark adaptation will find much, much sooner than what you'll find with autofluorescence. All right, so I need to unshare my screen, I think.
I stopped sharing your screen,
okay.
Dr. Gerson. I'll tell you what, we're going to put a poll question up for everyone as we're getting Dr. Hoja loaded in. And Dr. Gerson, if you want to answer a few more of these questions as we're preparing Dr. Hoja, and then for the remaining, we can go in and have you just type the questions in as Dr. Hoja is presenting, okay?
Absolutely. Here's one of my favorite things. What about smoking marijuana? Is that a risk factor for AMD? Smoking anything is a risk factor for AMD. Like I said, you can roll up kale and smoke it, and I would imagine that's going to increase your likelihood of developing AMD. What about zinc issues if you're putting them on an AREDS 2 so early? So I would never put someone on an AREDS 2 so early. So AREDS 2 is reserved for people that have at least intermediate dry AMD and is not for these patients with subclinical disease. So I can see that Joe's got his slides pulled up. So I'm going to mute myself. I'll answer some of the questions in the Q&A. Then when we're done, I think Joe and I will together answer some of the questions.
Excellent. Thank you so much, Dr. Gerson. I'd like to welcome Dr. Joe Hoja to join us this evening. He's a graduate of University of Western Ontario for his Bachelor of Science. He went on to get his doctorate at the University of Waterloo. He's in private practice in Peterborough, Ontario, and been doing so for the last 31 years. Thank you, Dr. Hoja.
Hey, thank you again for joining us tonight. I am your Canadian content for tonight. I promise not to say A, and I'm not going to refer to any beavers tonight. I'm going to try to make you feel at home. I'm going to give you some Canadian perspective. I was the first to do dark adaptation testing in Canada, and so I'll give you my perspective, and I think it'll answer some of the questions I saw about practicality here in Canada. So my disclosures, until tonight, no one before wanted to listen to me, so my only disclosure is that I am getting a paid honorarium from MacuLogix tonight to speak. So who am I? Like you heard, my name is Joe Hoja. I graduated from University of Waterloo, 1988. Yep, so that's 32 years ago, pretty old. Speaking of old, Peterborough is the oldest population in Canada. That's it, we're number one. So I think we beat out Victoria, Kelowna, some of those British Columbia cities, but we are the city with the oldest population. We're the home of the Peterborough Peats, the highest lift lock in the world. The lift lock is 20 meters high. For Dr. Gerson, that's 65 feet. We're home in the Canadian Canoe Museum, and now we're home of the first AdaptDx, or a dark adaptometry. We started with dark adaptation testing in 2018. So how did we get it first? Well, I know this guy. This guy beside me is Gary Kerman, and Gary Kerman is the first American optometrist to do dark adaptometry, and he lives in Hummelstown, Pennsylvania, very close to the University of Pennsylvania, where the technology was first developed. Also, I listened to this guy. You've been listening to him tonight. So Gary and I are both members of a practice management group, and Jeffrey came and spoke to that practice management group about 2 to 3 years ago. And so Gary was telling me about this technology 4 years ago, 4 years before I bought into it. And then I heard Dr. Gerson speak, and I thought, geez, I think the stars are kind of aligning right now. Peterborough, if any place should get it, it should be here. So we're in a fork in the road, or a fork in the river, as you might recognize Winnipeg. AMD is the leading cause of vision loss in the elderly. Peterborough has the oldest population in Canada, so dark adaptometry belongs here. Now, I don't make snap decisions. It took me 4 years to decide to do this, 4 years of hearing Dr. Gary Kerman talk to me. I am an early adopter, but it required a little bit of marinating. Now, dark adaptometry in practice, workflow and testing protocol. So I want to get a bit more practical about this. We tried many different testing protocols, each with different advantages and disadvantages. The main difference in Canada versus USA is here we don't have insurance billing codes for testing. So we're not going to talk about any CPT codes that the Americans have. Whenever you hear a lecture from the States, you'll hear, well, you can bill this code and that code. And as Canadians, we just sit back and say, we don't have any of those codes. But I'll suggest to you that this is both a challenge, but it's also an opportunity. So we have to charge the patient directly. We have to truly believe in the technology and prescribe it with confidence. Without insurance codes, though, we can charge what we think is fair. We get paid up front. There are no insurance discounts. There's no processing. And I show no favoritism to any hockey teams, although they're all Canadian. So here's our protocol. So we recommend dark adaptation testing for all patients 55 and up. We perform a rapid test, the test that Dr. Gerson mentioned. The test goes for 6.5 minutes, and if someone passes the test, they perform it successfully in under 6.5 minutes, and if they fail, the test just stops. 6.5 minutes is the cutoff. So we do both eyes, and we charge the patient $80. I recommend this test during my regular vision and eye health evaluation, and the patients come back and do it on a separate day. If the patient passes, patients pass, we congratulate them. Like Dr. Gerson said, congratulations, see you next time. For patients in their 70s who pass, we recommend testing it over again every 2 years. For patients under 70 who pass, in our practice, we recommend testing it about every 3 or 4 years. For patients who fail the rapid test, we give them an information package to read about AMD. The doctor follows up with them within 2 weeks, and we book them for a no-charge extended test. We've tried lots of different ways of doing this. We first started doing just one rapid test for one eye and charging them a smaller fee and then having them back. And then we decided to do an extended test right off the bat and then have them back later. But the rapid test, as it suggests, is quicker, and we can get both eyes done on the same day in under 6.5 minutes if they pass. So it's fairly quick, and we decided just to do both eyes on the first day. So we have them back for the extended test. We explain to the patient, we want to have you back to confirm the diagnosis. We may even say, we're going to give you a second chance, but it's also, from our point of view, to quantify the level of subclinical AMD they have with an RI score or rod intercept score. What's that number? Is it, it's over 6.5? Is it 8, 9? Is it 12? The number matters. So the RI score determines our treatment in our practice. For all subclinical AMD patients, we prescribe, as Dr. Gerson mentioned, lifestyle modifications, vitamins, proper sun wear, and we recommend that we repeat the extended test, but now we tell them that this is a test that there's a charge. We charge $107 for the extended test. So we repeat that in a year to evaluate their treatment success. We're giving them these recommendations. We want to find out if the test is succeeding or if the treatment's succeeding. If the RI is above 10, we also teach them Amsler grid home testing, and we may do the test more often than once a year. If the RI is above 17, we kind of feel that the adaptometry test has done its job. It's at the level now where we're going to start following up with them doing just OCTs. There's no real point of doing dark adaptation when it gets to that level. I'd like you to ask yourself, if I knew that I had AMD, or if I knew that my mom had AMD, my dad, my sister, my brother, my best friend, if I knew that someone that close to me had AMD, I would begin treatment as soon as possible to slow the disease process. Well, dark adaptation testing detects AMD up to 3 years sooner than we can. Why wouldn't we do this? No controversy. Our patients deserve the same care. So this is Eva. Eva's one of those classic patients have in your office. You see her every year. She loves you. She trusts me with her care. Eva's a hugger. She's also from Germany, and she tests my German language every time she comes in. She has no visible drusen, but her RI score is 13. She has AMD, and we're treating her because we care about her. We know she has a condition that should be treated. We wouldn't be treating her without the test. We wouldn't know. So you heard earlier today, patients or people with 60 and over have a 1 in 8 chance of AMD. This guy right here has a 1 in 8 chance of AMD. Yes, Wayne Gretzky is now 60. Patients over 75 have a 1 in 3 chance of AMD. So this guy down here has a 1 in 3 chance of AMD. We can do better. We can treat them sooner. We can detect it sooner. So optometrists, we're the unsung heroes. AMD patients can't yet be cured, but untreated AMD patients can get worse faster without treatment. So we are heroes if we delay that disease process. Who wants this result? Dark adaptation testing is profitable. So our AMD clinic revenue increased by over 200% from 2017 to 2018. So what that means is we track in our office what our revenue is in the clinic, and specifically testing related to AMD. And we acquired this technology in March of 2018. And in that short time, in the last 9 months, our clinic revenue increased by 200%. Now, the next year, compared to 2018, our AMD clinic revenue still increased by over 50% from 2018 to 2019. 3 reasons for increased clinic revenue to take it to new heights. Well, you get revenue from the dark adaptation test. You get revenue from additional testing, doing OCTs that you may not have done, 10-2, digital imaging. You get revenue from vitamin sales. So our vitamin sales increased in 2018 by 55% compared to 2017. Remember, that was just when we started. In March, we got the equipment. In April, we started ramping up. Didn't do it that much in the beginning, still learning how to do it. But still, in the last half to 3/4 of the year, our vitamin sales increased by 55%. But then compared to 2017, in 2019, our vitamin sales increased by 150% because we do the tests more. We have repeat sales of the vitamins. Those patients that start on the vitamins have to come back. They're repeat customers. Optometrists are by nature pretty conservative. We're almost boring. We often don't take risks. We are rarely early adopters. We're very careful. All this new technology is overwhelming. If you're like me, it seems like every equipment company has got their hand in my pocket wanting to sell me something new that's really expensive. So why this technology? There's a fear of missing the boat. Everything costs so much money. Is this the right time to invest? Especially now, is this the right time? Is this a time of challenge, or is this a time of opportunity? Dark adaptation testing is a win-win. Patients have better AMD outcomes. We're finding the disease earlier, and the practices increase revenue with dark adaptometry. Thank you for listening to me. I have just two last things I'd like to mention. One, a lot of you are listening to this because they heard about it from the Canadian Optometry Group. If you're not a member, I'd highly recommend it. Just go to the email group. It's all one word, Canadian Optometry Group. They're a great wisdom sharing group. And also, I'd like to just share a passion of something that I'm missing right now. I'm a big baseball fan, and like so many people right now, they're not seeing their sports. Dr. Gerson, I know, is a Kansas City Royals fan, and I'm a Detroit Tigers fan because I grew up only an hour and a half from Detroit. And I want to share my favorite memory of Kansas City Royals baseball, and that's when my favorite player, Miguel Cabrera, won the Triple Crown in Kansas City. And the Kansas City crowd was very gracious. The night he learned that he had won it, that means he had the most RBIs, the most home runs, the highest average. The crowd there was very gracious. They gave him a standing ovation. And I know Kansas City's maybe won the World Series a few times, but that was my favorite memory of Kansas City Royals baseball. So thanks, Dr. Gerson, for being such a generous presenter, and thanks for having great fans. Thank you. Back to you, Stuart.
Yes, sir. Thank you so much, Dr. Hoja. So we have got an overabundance of questions that have come into the Q&A. What I'd like to do is, Dr. Gerson, if you want to read a few of those questions, and you and Dr. Hoja can discuss them and answer a few. And then what we'll do beyond that for the audience is, if you want to remain on just for a few minutes, Dr. Gerson, Dr. Hoja are going to go through and type some responses through to folks. But more importantly, we'll pull a Q&A report. And if you've sent, we didn't get a chance to answer, answer, we will answer it offline directly to you via email after the program.
All right. Thank you, Stuart. So yeah, so this is great, getting a lot of questions. If we don't get to all of them, I just want to make sure I understand why, because we've got over 100 still unanswered, and I've already answered 42. So if we don't make them all, please don't take it personally, because we probably won't stay here for the next 3 hours. So in answering all of these, let me go through the most common ones that I've been answering, and Joe, you can tell me if your answer is any different. So probably the 3 most common are: at what age do you start testing patients? And my answer is I test every patient I see that's over age 60 or that has any night vision complaints. So Joe, I don't know if your answer is any different than that.
So we're big into simplicity, and we thought about all these case history questions, and we just made it a flat a protocol. If you're over 55, you do the test. Sometimes if someone comes in and they're concerned and they're 52, their mother had macular degeneration, then we may do the test just because they're interested, or someone with other risk factors, but it's pretty simple in our office. The staff know. In fact, they even highlight the patient's age for us so the doctors don't miss it. If this person's 55 and over, we're recommending the test.
Yep, great. So the other one was, if you identify someone that has impaired dark adaptation, 2-part question: is there anything else that could be other than AMD, and what do you do about it? And so the answer of what else could it be besides AMD is it could be a systemic vitamin A deficiency, which is pretty darn rare, at least in the developed world like Canada and the US. Or it could be a retinal dystrophy or degeneration like Stargardt's RP, which you're going to know about before somebody's age 55 or 60. So those are the only other things that will give you a impaired dark adaptation with this test. And what do you do if someone has impaired dark adaptation, if they have subclinical AMD? And I'll give my simple answer and let Joe expand on it and put it in more specifics for Canadians. For me, that means someone needs to be on a supplement that is carotenoid based. And I don't know that there's any one definitive right answer. The right answer is you have to do something. So I'll defer the rest of that to you, Joe.
Well, your talk pretty much explained exactly what we do. The patients who fail the test, we give them a very detailed package on macular degeneration that describes the test, it describes what are their treatment options, and then we sit down and we speak with the patients in detail about what we'd recommend they do. And so it includes all the things that you've mentioned. We recommend a specific vitamin for macular degeneration. We recommend sunwear that blocks blue light. We talk about their diet. We talk about their general health, and we follow them more often now because we've identified they have a problem. We may do genetic testing if we see our treatment isn't succeeding as well as we'd like, but we kind of hold that in our back pocket for later on. If we see that all the things we're doing aren't working, then we discuss the option of doing genetic testing to further personalize their care.
Yeah, you know, there's been a number of people that have asked about genetic testing, and so Joe, it sounds like you do genetic testing.
We do, yeah. So I know it's a controversial subject, and so some ophthalmologists are not convinced, some are, but our opinion is to err on the side of caution, and there's no harm in doing the genetic testing, and so we are in favor of doing that. I know this lecture is not a topic on genetic testing, but we are doing it on many of our patients who have either early or advanced macular degeneration or don't seem to be successfully treated with the other options that we've given them.
Great. So a number of people, actually probably the most common question has been, well, one's been, what vitamins do you suggest? So Joe, let me ask you, are there vitamins in Canada that we don't have here in the US? I think the answer is yes. I'm just not familiar with all the names.
Well, there are how many different macular vitamins are there, right? I mean, we probably can't count how many there are in the stores. But the ones that are in the States are similar to here. We can't get the ZeaVision products that I know, Jeffrey, that I think you were using those before. But we have all the different AREDS formulas. We have MacuHealth, which is available in the States, and we have a Canadian version of that called Vision Essence that we use a lot of. So the most popular vitamins, I think, in Canada are similar to what's in the States. We do have the advantage of having a sort of a homegrown version of MacuHealth that's a little less expensive for us.
Yeah. The other question that's being asked a lot, and I fully understand that this is a COPE talk, but this is a question that's being asked, probably had 15 or 20 people already asked this. What device do you use, and how do you get it, and how easy is it to do in the office? Joe, do you want to take that one?
Sure. So to date, there's only one piece of equipment that does dark adaptometry testing, and that's the AdaptDx. And so we were the first practice in Canada to import that. The test is a tabletop version right now, but I'm really excited about the virtual reality version of this that's coming out. I know Dr. Kerman and I are hoping to be the first in our respective countries to have that particular technology. The dark adaptometer has a limitation in that you need space for it. And so you need a pitch black room. Room has to have no light at all. So there are challenges for setting that up. But this new device, the virtual reality version, the AdaptDx Pro, solves that problem. And even though we are already set up with the tabletop version, I'm excited to get the new one because we can do it in any room. So we can take the patient out of this special testing room and maybe do it in other places in the office and save the room for other tests in the future. So a lot of the problems finding space for the technology has been solved with this new version. So it's the machine made by a company called MacuLogix.
Great. Yep. I'm just looking at some of these questions. For the Americans that are on here, there was a question, is there a CPT code for this? And the answer is yes. Someone's asking, how long does dark adaptation testing take? And the answer is it depends. And so really what it depends on is if someone has no AMD, it will take less than 6.5 minutes. If they have any AMD, subclinical or clinical, it will take longer than 6.5 minutes. The maximum period of time is 20 minutes. Once you hit 20 minutes, the test times out.
That's per eye.
Per eye.
Right.
Yeah, but Joe, do you test both eyes?
We do. For our first patient, for the first screening test, we do 2 rapid tests in the same appointment. So many patients kept saying, what about my other eye? You didn't test that. So we got tired of answering that question. The answer is that 92% of the people have the same results for each eye. However, that other 8% seems to pop up quite a bit. And so we've just decided that we're doing both eyes on the first visit, both rapid tests. So if the person passes, they're getting done in whatever, less than 6.5 minutes per eye. So maybe under 10 minutes.
Yeah.
So we schedule our patients at half-hour appointments just in case they don't pass the test, but it's 6.5 minutes or less per eye.
Yeah. You know, what I'll tell you, Joe, is I actually don't test both eyes because of exactly because of the science that you cited, that it's a fairly small percentage that'll have any difference between the two. You're absolutely right. It can happen sometimes. You know, you mentioned earlier that you like systems and you like things that are practical. And I'm just the same way. So I always let my staff know that we're always going to test the right eye, and unless there's some reason I tell them not, to switch. And we're always going to do just one eye. And we try to keep it simple. There are cases where we end up testing both, but that's, for me at least, that's kind of the rarity. That's definitely not the average. A question that keeps coming up over and over and over again, and Joe kind of addressed this, but I want to touch on it also, is, a lot of questions of what do you think about fill in the blank specific supplement? And I'll give you my very simple, and Joe, you tell me what you think. My very simple answer to that for any of these subclinical patients is if you name one and you say, what do you think about it? If it has carotenoids in it, my answer is yes. I think the most important thing is a carotenoid-based supplement. Exactly which one, I don't think it really matters. I just think what's really important is you get them on something sooner rather than later.
Well, the only contradiction to that is there is some evidence that says that the level of zinc may be a risk for certain percentages of populations. So the vitamins we put patients on, we put them on a zinc-free version of a carotenoid-based supplement. So the Macula Health or the Vision Essence, those are the vitamins that we use, and they're a triple carotenoid formula. And we know that's going to be better than anything they're using so far, because most of them aren't doing anything. And then if we find that we have to get more personalized, then that's where those genetic tests find out if they really have any zinc sensitivities or if there's something more personalized we can do. So that's how we do it in our practice.
Yeah. So one of the questions here is, they're asking you, Joe, does a tech need to stay with the patient during the test?
Absolutely. The dark adaptometry test has many similarities to a visual field test. And so for those of you who remember doing visual field tests, I hope none of you doctors do that, but sometimes you have to hold the patient's hand and you have to say, keep paying attention there, Mrs. Jones, you're not looking in the right direction. So dark adaptometry is the same thing. They're in a dark room, it's 6.5 minutes plus or minus, and people need to be coached. So yes, there is a patient, staff members in there all the time in a pitch black room. Now, this new technology that's coming along has artificial intelligence, and it may be that the staff member doesn't have to be actually holding their hand as much in the future, because I think the actual machine will follow them and watch for mistakes. So that's another part I'm excited about with the new technology.
Yeah, so Joe, I would tell you, from having seen and had it on and had some of my patients use the AdaptDx Pro, the newer technology, is it really can be run independent of a technician. Really all you need a technician for is to help them set it on their head, press a little control. I think it's 3 presses to start the test. So which eye, which test, and go, and it talks them through it. It actually talks to the patient and leads them through the test. So it makes it pretty easy for patients to be able to do. So Joe, why don't you just do OCT instead of more involved dark adaptation testing?
Well, the AdaptDx test finds the AMD before an OCT. So almost, well, as Dr. Gerson said, this test finds things up to 3 years before any other technology finds it. So we can do OCTs, but we're still going to miss subclinical AMD. The AdaptDx test finds it sooner than that. So it's not wrong to do OCTs as well. And I know post-COVID, a lot of practices are thinking of just standard of care doing OCTs in everyone. If you do that, you're still going to miss subclinical AMD. It happens before the OCT.
Yeah, I think that's a perfect answer. As accurate and as incredible resolution as OCT has, it's not good enough to find these subclinical, very, very minute subclinical changes. Let's see.
Dr. Gerson, I want to add also, as you're looking maybe for the last couple of questions, that the survey that goes out to everyone will have some detailed questions about if you want to get more information about the product, and if you want to be contacted for call structure and things of that nature. I know there's a lot of questions in the Q&A about that. So if you respond accordingly in the survey, you will get more information as well.
Great. Yeah, because that's a pretty common, pretty common question. The other one that I'll also guide you on is there's been a number of people that said, hey, where do I get the study that you referenced? On MacuLogix.com, they've got a science section where you can get all those, the actual scientific papers. So if you're asking about specific papers, that's probably the best place to go and get it there. Joe, I don't know if you're looking at questions, if you want to pick any to answer. If not, I'm kind of going through here. So, you know, the other one, I've answered some of these. I can't remember if I answered it verbally yet or not. What else can cause impaired dark adaptation? I think we did answer that it could be systemic vitamin A deficiency or retinal dystrophy or degeneration. So I think we already did answer that.
I see one here. It says, do you measure dark adaptation in practice? Do you measure it in another exam slot? Well, we have the patient come back on a separate reasons for that. One is flow. The test will take some time, but also any test you do in your exam room that flashes light in their eye can affect their ability to do the test later on. So even if you did like an optomax scan or any ophthalmoscopy, that will make the test impossible to do because they need their rods and their cones to be fully functional, no bleaching out at all. So we want them back on a separate day. We have a special testing room, so all our patients come back and do dark adaptometry on a different day. The same way we bring them back to do OCTs, visual fields. It's just a separate scheduled appointment.
Yeah, you know what I would tell you is it doesn't matter. Doesn't matter what technology you're looking at, right? It takes some figuring out logistically for how it's going to go into your practice. And so I would tell you anything that you're looking at is going to create some change in your logistics of how things flow and what you're actually doing. Let's see. There was a question about can you have drusen and not fail dark adaptation testing? And so, you know, what I would say is the answer is yeah, you can have very small drusen. They're actually called druplets, less than 63 microns in size, that can be just age-related changes that are not degeneration. So you can. And so, you know, really the better question, you know, how can you tell if someone has small drusen, whether it's macular degeneration or not? The answer is through dark adaptation testing. What about peripheral drusen or familial drusen? What do you think about those, Joe?
Well, I think the AdaptDx just gives you just another piece of information to help you make that decision on whether you're really seeing AMD or not. I mean, there are certain cases where you might think something is drusen and it really isn't. So no test gives you the full answer. Just like in glaucoma, you don't rely on just your IOPs, you don't rely just on an OCT. So the AdaptDx is just another sort of piece of equipment that helps us make some clinical decisions. So we use it to guide us towards treatment. There was a question in there about why don't you just do OCTs on all your patients? And that's a valid possibility. I'm becoming a little bit more price conscious with our patients. I don't want to nickel and dime my patients. And one advantage the United States does have is you do have these CPT codes. You can do your rapid test on one day and have them back and do an extended test on another day, and you're billing these codes. But when we started doing the first test, we were having them for a rapid test, charging them one fee, saying, oh, you failed. Now you have to come back for the extended test and then pay again. And I started to feel, well, that's just not fair. The patient's saying, well, why didn't you just do the longer test in the beginning? So it's in Canada, most of these tests, the patient has to pay up front. And so we have to be careful not to give too much sticker shock for patients and choose things wisely and put ourselves in their shoes. And so we try to customize our care based on the patient. And so it's a little bit of a dance in Canada. We don't have as many codes to use, but again, that's an opportunity because the appointments that we do charge for, we get paid right away, and there aren't any discounts that we have to worry about. There's no at the end of the day how much the insurance company is willing to pay, and there's no waiting for when they actually pay.
So Stuart, I'm going to ask you a question. How many of these questions do we answer? How long do we go? And I only ask because as fast as we're answering and I'm typing, the numbers keep going up. We're at over.
They are. And I see a lot of people are starting to exit the session, and I think we've surpassed our time a little bit. I would say this again: we've saved the Q&A, and we will download that so we can continue to try to get some answers out to folks that are not repetitive answers. And then as well, most importantly, please fill out that survey with detailed information, and that will get you the continued answers that you're looking for. So that's concluding the evening at this point. So thank you so much, Dr. Gerson and Dr. Hoja.
Thank you, Stuart, and thank you to MacuLogix.
Yeah. Nice work.
Absolutely. Again, just to remind everyone, we will get CE certificates out following the surveys. Surveys will go out tomorrow morning. CE certificates will go out about 24 hours thereafter, and we will electronically upload the hours to the COPE website, as well as submit those to the Texas boards for Texas doctors. Thank you so much. That concludes the presentation.
Nice working with you, Jeffrey.
Yeah, you too, Joe. These questions, it's crazy how many questions are coming in.
Yeah. Yeah, I'm impressed with how many Canadians showed up